introduce you all to Dr. Baah. Emmanuel Baah is from Ghana, and he practiced medicine in Ghana before he migrated to the United States. Here in the US, he recently graduated from UNC Charlotte with a master's degree in epidemiology in May of 2020. His areas of interest include genetic epidemiology, nutrigenomics, and nutrigenetics. And Dr. Baah has been working in our human research core, particularly with Dr. Moulton Kohlmeyer, to strengthen our training programs in precision nutrition, especially working with fellow physicians. Dr. Baah recently enrolled in a PhD program at UNC Charlotte, so is pursuing even more advanced knowledge in these fields, and we are delighted to have him here to speak with you today. So, Dr. Baah, I'm going to turn it over to you. Thank you for being here to speak with us.
Hello?
Yes, all good. I can hear you perfectly.
Okay, perfect. And I'll start sharing my screen.
Fantastic. I can see your slides as well.
Okay. Hello, everyone. I was saying earlier to Sarah that I must have broken record for presenting in multiple days. If you did join us the last time, unfortunately, we couldn't go through with the presentation. Hopefully today everything goes well. And I'm glad to have you back. I'm also excited to present the findings of this epidemiological studies. As Sarah alluded to, I have formal training in epidemiology. What that simply means is we do study a lot of things, usually diseases, but in this case, nutrition at the population level. So we want to understand various things relating to nutrition that affect the population as a whole, and also ultimately the individual. So that is my background in terms of training. I'm also a physician by training, and currently I'm studying to have my PhD in computational biology and bioinformatics. Basically what that means is being able to use computer simulations and algorithms to solve scientific problems. All right, so the last time we spoke, I was excited to present to you, this is a secondary analysis of data from Enhance. We talk a little bit about Enhance later on. We wanted to understand the relationship between obesity and the development of arthritis. So over here, the ultimate goal is have a general overview of arthritis and obesity, what they are, and then examine the relationship between obesity and the risk of developing arthritis. When I say examine the relationship, you're looking at, there are so many factors that may affect this kind of relationship, being it genetic, being it environmental. So this study looked to investigate some of these factors to see how they affect, if at all, the relationship between arthritis and obesity. So a little bit about arthritis. So arthritis basically is most for, hello? So arthritis for the most part is the most common cause of disability among adults in the United States. We have about 24 million Americans suffering from various forms of arthritis. Again, there are so many different forms of arthritis that we will see later on. And usually it is caused by inflammation. When there's inflammation on the joint, usually the joints of the hands, the joints of the knee, the ankle, that's when you have arthritis. And usually it's characterized by pain. Now, in terms of inflammation, we have acute inflammation, which could be caused by anything, a number of things. It could be caused by infections, it could be caused by injuries, but usually infections and injuries caused inflammation. Inflammation caused by infections and injuries may last for a shorter period. Now, when it's less than 6 months, it is acute. But when it extends beyond 6 months, it's referred to as chronic. Now, in case of arthritis, you have inflammation that extends beyond 6 months. So it's a chronic inflammation which leads to pain. Usually one experiences it for the rest of their life once they get it. And it's really common among the aged, particularly those who are 45 and above. But nevertheless, it affects individuals of all ages and gender as well as race. So in terms of pathophysiology, this is what happens. So this is a typical picture depicting the pathophysiology of arthritis. So basically there's an injury, or sometimes there's an infection and in the joint. So on the left side, you see a normal looking joint of the knee. So we have every structure in place, looking good. You have your meniscus, you have the articular cartilage that protect the knee. Now, in an event of an inflammation, whether injury induced or infection induced, then you have a breakdown of the bones around the knee, and it leads to pain for the most part. So this is exactly what happens when an individual begin to experience arthritis. And again, it's not just the knee. It happens in the hands. It happens in other parts of the body. Sometimes the discs behind our back. So basically, wherever there is a joint, you may be able to experience arthritis when there's an inflammation. In terms of risk factors, you're looking at age, gender, race, diet, physical activity, smoking, and alcohol consumption. These are broadly under genetics and then environment. So these factors usually influence or the development of arthritis. Again, the effect of arthritis, of course, health-wise, is debilitating for an individual to experience arthritis because it is a lifelong kind of condition once you get it. But in terms of economic and social cost, it does really cost a lot in terms of medical bills. So individuals with arthritis, we're looking at an extra $2,000 on their medical bills monthly, which is a lot. In a year, we're looking at 140 billion. Again, the United States system spends a couple of trillions on healthcare. And if arthritis alone takes a chunk of it, you can tell it's really costly. And usually it's around ambulatory care when it comes to arthritis. Of course, individuals experiencing arthritis sometimes are unable to attend work, and therefore they miss time off, so there's a loss of wage. And of course, lastly, it's also physically demanding on the individual. So arthritis does have both health implication and as well as economic implication on the individual. I remember, so that brings us to the types of arthritis. So there are so many different types of arthritis. So I would say that these are the common ones. And I would say that these are the main ones: rheumatoid arthritis, osteoarthritis, and psoriatic arthritis and gout. I'm saying these are the main ones because there are so many different types. Arthritis might happen to your hands. So it's often described as arthritis of the hand. So whichever part of the body arthritis happens, you can name it that way. So arthritis of the knee, arthritis of the hand, are all different kinds of arthritis. But broadly, these are the four main types: the rheumatoid arthritis, the osteoarthritis, and then psoriatic arthritis, as well as gout. Again, I'm not going to spend too much time on these because that is not the focus of this research. Now, the focus of the research is, does obesity actually contribute to the development of arthritis? That is the focus. So we know that obesity is a known risk factor for many diseases. So when you take the top 10 diseases in the United States, the top 10 leading causes of death in the United States, according to the Centers for Disease Control and Prevention. The top 10 usually, we have cardiovascular diseases, we have stroke for the most part, and then we have cancer. All these diseases are directly linked to obesity. Obesity is known risk factor for all these diseases. And again, our focus here is on musculoskeletal disorders. Basically, we are looking at your skeleton, anything that has to do with your skeleton. And obesity is also a known risk factor for musculoskeletal disorders. And arthritis is also a musculoskeletal disorder. That is what generated the interest to investigate the relationship. Now, I must say that even though it's well established that obesity is a risk factor for the development of so many diseases, including musculoskeletal disorders, when it comes to arthritis, there's little research done. So we do not understand the pathway, what actually about obesity leads to arthritis. And we do not understand fully well the mechanism behind it. So this is a first step, or one of the few steps towards answering such a question. So that is why this study was conducted. Of course, we have to, first of all, have a working hypothesis. What might be the cause? This is a picture of depicting individuals who are healthy and individuals who might be obese and morbidly obese. So the working hypothesis here is obesity causes general inflammation. So obesity is a pro-inflammatory condition. And again, it also has a mechanical aspect to it. Mechanical in the sense of the weight that obesity places on the joint. So you have increased wear and tear because of excess body fat on the body, usually on the joint, particularly the knee. So remember the causes of arthritis. I just brought this picture back here on the right. So once obesity places pressure or a lot of weight on your knee, will increase the wear and tear and therefore facilitate the inflammation, which might lead to obesity. So that's the first working hypothesis. The second is what is systemic inflammation. Again, I don't want to go into details because that is not the focus here. So whenever there is excess macronutrient, energy imbalance, you develop obesity. And once you develop obesity, this is how obesity causes systemic inflammation. So there are cells called adipocytes, fat cells in your body. So alongside macrophages, they call what is called inflammatory markers. So here we have the TNF, tumor necrosis factors, and then we have interleukin-6, mostly involved. So adipocytes, excess adipocyte calls these pro-inflammatory markers into play. And then it reduces adiponectin as well. So there's an off balance. The imbalance, there's an off balance between homeostatic, there's a homeostatic imbalance. That is the word I was looking for. And normally, as it goes on, for a chronic inflammation, then the liver begins to produce specific inflammatory markers, such as CRP, C-reacting protein, and then ESR. So the working hypothesis here for obesity being a risk factor for arthritis is one, its mechanical influence in terms of the sheer weight that it puts on the joint, causing increased wear and tear, and also the systemic inflammation obesity induces. Okay, last week we did go over this, so I'm not going to spend time. So this is for simplicity's sake. We usually look at the obesity map chart to kind of estimate if an individual is obese. So you look at the individual's height, and then you look at the individual's weight. So you look at the weight, and then you divide by the height. So the weight, if the weight is in kilograms, you divide by the height in meters squared. So that's how we estimate if an individual is obese. So on this chart, if for an individual who is 4'8" and weighs about 160 pounds, will be considered obese. And for the same individual, if the individual weighs 190, will be considered morbidly obese. So this is, and of course, we talked a little bit about this last time for the benefit of those who couldn't join us the last time. So obesity is a global problem. It's not just an American problem. So this is a distribution map of obesity around the world. And clearly you can tell that in northern part of America, you have the United States, you have Canada. It is a big problem. And down south too, you have issues when it comes to obesity. And of course, Australia, and then also the northern part of Africa, and of course, Europe, and then also Russia. And I just wanted to play this to you over the years, how obesity rate has increased in the United States. So you see from as far back as 1987, obesity has been increasing over the years in the United States. So this is the latest version of obesity prevalence in the United States. So 2019, you can tell that it's becoming worse over the years. The key question here is, where is the overlap between obesity and arthritis? And the place to start from is looking at the risk factors for both obesity and arthritis. Again, they all fall under a bigger umbrella of gene and environment. So on the left side, you have obesity, risk factors. On the right side, you have risk factors for arthritis. And interestingly, all the risk factors for obesity are also the risk factors for arthritis. We're talking about age, gender, diet, physical activities, a person's socioeconomic status, looking at education, occupation, everything that is linked to arthritis is also linked to obesity. And even more, in terms of arthritis, obesity is actually listed as a key risk factor for the development of arthritis. Of course, infections and diabetes also can lead to arthritis. We are not getting into that. Our main focus is on obesity, how obesity actually leads to arthritis. So now to the study. So again, as I mentioned, this is a secondary study. What that means is we extrapolated data from the CDC. There is a part of the CDC, or an organization under the CDC called the National Health and Nutrition Examination Survey. They actually move around the United States every year in tracks like this, a big tracks like this. And usually they come with physicians, they come with nurses, they come with lab technicians. So these tracks are really equipped with important medical instruments to be able to do virtually everything that you can do in a hospital. So ENHANCE collect data, they collect socio-demographic data, and then they collect samples as well, and then they collect medical data on Americans. So it's representative of America. So they have their internal algorithms where they select specific areas to go to. So for all you know, sometimes they might show up in Kannapolis. So if you see a track like this, it is important. Even you are interested in contributing to science, you may want to approach the track and see if you can help. Again, it's under the Centers for Disease and Control, Centers for Disease and Control and Prevention, the CDC. So CDC, so basically Enhance makes sure the data is representative of the people of the United States. Besides prisoners, people who are institutionalized, often people who are in prisons and people who are also in hospitals, everybody kind of is becomes, the target population is everybody, basically. So they do both medical, dental, and physical and physiological examination. So at the end of the year, they put the data together, and these data are easily accessible. Now, there are some part of the data that are not in terms of genetics. If you want to access the genetics associated with the data, you really have to go through a whole levels of loops to get them. So, but other than that, most of the data is readily available. So when we talk about obesity rate or the prevalence of diseases, some of these data are actually coming from the Enhance project. So as a statistician, what I did was to extrapolate the data that we need to answer the question if obesity is actually related to arthritis. And also look at the risk factors. So we talked about age, we talked about gender, we talked about socioeconomic status, including your education, your poverty level. And also the data also has markers, pro-inflammatory markers that we could use and to analyze if indeed inflammation is also a reason for the development of arthritis. I mean, inflammation caused by obesity as a possible reason for the development of arthritis. So in terms of demographics, we pulled data from 2012 to 2018. So Enhance always releases the data biannually, so every 2 years. So we were up to date. So we expect the next one, 2020. By the time that this analysis was done, 2020 had not been released yet. So in terms of demographics, a total of 17,000 people were included in this study, which is a lot. 17,000, not from a particular place, but all over the United States. And in terms of race, you have more non-Hispanic white compared to other races. And if you can clearly tell that it is really representative of the United States. I know the demographics of the United States is changing and it's changing state by state. But generally, we still have a population that is dominated by non-Hispanic white. So right from the bat, it tells us that we have a good sample to work with. And therefore, our results would actually be representative of the people in the United States. So we had so the data out of the 17,000, 79%, almost 80% were individuals above 30 years old, either 30 or above. And most of them were women, even though it was mostly evenly split between men and women. So we had 52% basically of women responding to the survey. And a substantial number of people consider themselves not to be poor. That's 85%. So in the United States, quickly, there's a poverty level index that the government set. That is, if you earn a certain amount of money, then you are considered either poor or not. So that is the metric that was used in this case. So individuals who indicated to earn more than the poverty level set by the government were 85%. And most of them were college, they were not college educated. So 69% had not gone to college. So first thing we did was to use statistical tools, so many statistical tools professionally to analyze the relationship. So the first thing we did was to analyze the relationship. And indeed, everything pointed to the fact that obesity actually leads to arthritis. Of course, these tools may not tell us why, but they may allow us to analyze certain important indexes and factors, such as the risk factors involved in both obesity and arthritis. And we can make inferences from such analysis. So first of all, we did find that there was a strong relationship between, a significant relationship, I might say, between obesity and the development of arthritis. And this is a graph of what we found. So in the 17,000 people, so the x-axis will be here, your vertical line will be increasing BMI, body mass index, basically used to indicate a person's obesity status. And then up here, the y-axis indicate the percentage of percentage. So when you take individuals with lower BMIs, 20, less than 20, the blue here represent those without arthritis, and the orange represent those with arthritis. So if you take individuals with BMIs of 20 or less, those without arthritis were way more than those with arthritis, significantly more. You can tell the difference. Now, the beautiful thing about this result is the fact that as you increase the BMI, now from 20 to 25, and then 36 to 30, those individuals without arthritis begin to fall, whilst those with arthritis increases. So this is a kind of strong correlation, significant correlation. And using statistical measures, there's something we call p-value. P-value allows you to determine how significant your result is. The p-value is 0.001. Usually you want a p-value of less than 0.05. So this shows a significant relationship. So as BMI increases, individuals with arthritis level increases. At the same time, individuals without arthritis decreases. So this is really exciting. And considering that it's coming from a fairly representative sample of Americans, this was really good. And again, this was conducted combining data from 2012 to 2018. So the prevalence, according to the data that we collected, showed that obese individuals were 40%. Now, the 42% is the current prevalence of obesity in the United States. But our data showed 40, which was not entirely off. And besides, it was up till until 2018. So the data has been updated. And the prevalence of arthritis using the data from 2012 to 2018 shows that 27%. Current data, CDC data shows that 22.7% of Americans do have obesity. So not entirely off. All right, so this is the result. I just put it up there here just to show that we did something. It's a little bit confusing, so I'm going to break it down in the next couple of slides. But what I want to point out here is we looked at almost every one of the risk factors. So we looked at obesity right here. We looked at age. We looked at gender. We looked at race. We looked at educational level. We looked at poverty income ratio. So basically we looked at smoking level as well as physical activities, alcohol, and drinking. So we looked at how these risk factors actually affect obesity and or arthritis. Again, using sophisticated statistical tools to do that. And this is basically what we found out. So obese individuals were 55% more likely to develop arthritis. And most importantly, as an individual ages, their level of developing arthritis increases significantly. So if you're 30 or more, you have 10 times the probability of developing arthritis compared to somebody who is less than 30 years. And this relationship that we explored, we realized that it was a linear one. So at 30 years, there was an increase. At 31, 40, 50, so there was a linear relationship. Increasing age increases an individual risk of developing not just obesity, but also arthritis. And also females were more likely to develop arthritis compared to males, according to the data. And individuals who were poor were 36% more likely to develop arthritis compared to individuals who were not. And individuals who consume alcohol. So the metric here was you drink at least 14 alcoholic drinks per week. Individuals who drank that much were 24% more likely to develop arthritis over time. And lack of physical activity. I will explain lack of physical activity in a moment. So basically, we are looking at moderate to intensive exercise. Moderate means brisk walking for at least 30 minutes, 3 times a week. So lack of physical activity, those who lack physical activities were 24% more likely to develop arthritis compared to those who were not. And less likely. Now, so in statistics, you usually have a reference point. So our reference point in terms of race was white. And it's not because, it's simply because white, non-Hispanic whites were the most in terms of population-wise. So we're comparing everyone else to non-Hispanic white. So if you compare all other race, Hispanic white were more likely to develop arthritis. So what that means is, so what this simply means is, if you compare Hispanics to non-Hispanic whites, Hispanics are less likely, 57% of the time, to develop arthritis. And Blacks are less likely, 35% of the time, to develop arthritis. So basically, the flip side of this result says most non-Hispanic whites, are likely to develop arthritis. So whites are most likely to develop arthritis. And then smokers. So I put a check mark on smokers. So it says smokers are less likely. We found out that smokers were less likely to develop arthritis. Now, initial part, if an individual starts smoking, now the results did show that once you start smoking in the acute phase, you had an increased risk to develop arthritis. But over a person's lifetime, the risk reduces and smokers were less likely to develop arthritis. Now, I don't want to go into this because we've not investigated it, but if I'm guessing, smokers are more likely to develop other forms of diseases and probably might not be obese, and therefore are less likely to, are most likely to, less likely to develop arthritis. Again, this is just a thought. We did not investigate it, but what the results said is what I'm putting out there. Smokers were less likely to develop arthritis. All right, so now the key question that we're looking at was, okay, so between mechanical effects of obesity and inflammation, which is actually more plausible as an indicator or as a cause, quote unquote, of arthritis. So we looked at specific inflammatory markers. In this case, we have the C-reactive protein, and erythrocytes and meninges rate. So these are markers that you can actually measure. When you go to the doctor's office, the doctor can actually measure your CRP and ESR and can tell you if you have inflammation. Now, again, I must stress that if these are elevated, it doesn't mean you are obese. Now, infection can cause these to elevate. There's so many diseases, chronic diseases that can cause your CRP and ESR to increase. If you have cancer, usually your CRP, ESR are just indicators of inflammation. It doesn't tell you why. Now, the reason why I want to explain this is that the ESR and the CRP was taken on the day of visit of study participants. So what that meant was, or what that means is, if the individual had been experiencing any other thing causing the inflammation, it would be hard to tell what it was. So an individual might have come in with an infection and the CRP level or ESR level was high. So I must say before I put out the results that this is really not a fair assessment. It is some assessment of how inflammation affects obesity and also arthritis. But I just have to explain why we don't want to hang our hat on it. That is why in an association test like this, association test usually is the first step. It tells you, it gives you an idea what is happening, and then you can actually do a controlled trial, randomized controlled trial to actually confirm your suspicion. So this is just the first step. So again, having said that, we did not find any significant difference between obese individuals with arthritis and obese individuals with arthritis. So among those with arthritis, we looked at who were obese, who were not obese. And we looked at their CRP levels and then their erythrocyte segmentation rate also, and realized that there wasn't any significant difference between them. So what that simply meant was, if you were looking at inflammatory markers linked to obesity being the reason for the cause of arthritis, it is unlikely that was the case. Again, this could have been totally, this could be totally wrong based on the fact that inflammation can be caused by so many things. But again, as an association test, we just wanted to understand what that meant. So again, I'll reiterate that. So the absence of a result does not mean it doesn't exist. I need to highlight that. But looking at our result, at least with the working hypothesis, mechanical effect as well as inflammatory effect, it will be safe. It will be safe to make the inference that at least obesity-induced inflammation might not be the reason driving the higher rate of arthritis. And if anything at all, so in science, you always have a hypothesis. There's something called your first hypothesis called the null hypothesis, and then the second hypothesis called alternate hypothesis. And then, so if inflammation is not the cause, then with some level of certainty, we can make the claim or the inference, that's the right word in science, that the mechanical effect of obesity might be the driving force. So here, inflammation, if inflammation is occurring, it is mostly as a result of the pressure weight put on the joint and then causing an injury. Again, this is only an association test. It gives us a fair idea of what is happening. All right, so in summary, I just want to say our study results highlighted these 4 important things. Again, there were other equally important things. Obesity gender, age, physical activity. So when it comes to obesity and development of arthritis, these four things are very, very, very important. Again, I'm not going to go into why, and because this is not what the study did, but of course, scientifically, you can explain, you can give reasons why these are risk factors. Broadly, you would agree that your genetics play a very, very, very big role when it comes to diseases, and especially obesity and arthritis. So as a study, you want to draw some conclusion and make some inferences. So based on our study, we just want to, as a nutritional research, we just want to encourage people, because that's the only way to maintain a healthy weight. A healthy weight means having an energy balance. Now, again, I'm saying this with a grain of salt. The recommendation is always at least eat 2,000 calories per day. Now, if you want to maintain an energy balance, the goal is not to just count calories. That shouldn't be the goal. The goal is to have the right amount of food at the right time. Now, counting calories might not give you the expected results. So I need to caution that. And what the second most important thing when it comes to weight management, besides what you eat, is physical activity. And this is the recommendation. So we're looking at, so we have moderate to high activity. And moderate to high means moderate means you are having a walk, brisk walk with your hands going up and down. That is what is referred as moderate. So for adults, we're looking at 30 minutes a day. So a total of 150 minutes in a week is good. And for individuals who are older, 65 and above, brisk walking alone is good. So there've been several research that has highlighted weight loss. I know there are so many studies and protocols on how to lose weight and all those things. But the bottom line, studies have confirmed over and over, is a simple attention to what you eat, and merely walking this amount a week can take care of it. So at the end of the study, this is the recommendation that came up with. All right, so quickly, I just want to acknowledge these people. Dr. Kohlmeyer is my PI. He's the man that I work for or with under directly. He's the director of the HRC. He's been enormous on my career, and I can't say much about how impactful he has been. Of course, Dr. Steve Zazel, the immediate past director, has also been a mentor to me since I started my career as a postdoc here at the NRI. And Dr. Susan Sumner, who has been also a teacher for me since I got here. When I got to the NRI, I had little experience with research. Now I'm gaining much experience thanks to the mentorship of these people and many more at the NRI, which I appreciated. I couldn't have started my research career in any area better than the NRI. And of course, I want to thank all the HRC staff for their support. Thank you very much. I'll end here for any questions.
And thank you, Emmanuel, for speaking and sharing your research today. As he said, the floor is open for questions. If you'd like to leave a question in the chat or via the Q&A, I see one has just popped up, so I will share that with you. Emmanuel, you have a question that came in from Larissa Mazapina, and she would like to know, could weight loss be effective for treating arthritis, or are changes in joints irreversible?
Okay, thank you. That's a great question. So first of all, yes, definitely weight loss will have a significant impact on your development of arthritis. If you're able to cut it down before it begins or at the early onset, that would be good. Now, in terms of it being reversible or not, now if you remember the the picture that I put out there. Inflammation. Once the joint begins to get damaged, at some point you cannot replace. You cannot reverse it. It cannot be reversed. The only thing that can be done is to replace it. So you have individuals with knee replacement. Yes. So early onset, reversible, late, not so much so. Hello?
Free, everyone. We are still open to questions. Thank you for answering that first one, Dr. Baah. If you have them, you can place them in the chat or you can place them in the Q&A. I'll ask you a quick question, Dr. Baah. Are you interested in using the information that's available through that data set to do any future research? Or will you stop here with this arthritis research? I feel like there are so many possibilities.
Oh, yes, good question. So first of all, this has not been published yet. So we are in the process of getting it published and recognized nationally and internationally. So that's the first thing. Secondly, yes, it tells us to, at least it points us to the right direction. So we want to investigate further how the pro-inflammatory markers, such as the CSR and then CRP and ESR actually contribute to, if at all, to the development of arthritis and the role of inflammation in general. So yes, this is something that we hope to explore. Again, for a secondary analysis, you only have an idea. So it's usually not causality. You want to do a randomized controlled trial to kind of confirm all your suspicion.
Wonderful, thank you. I'll still allow for some more questions to come in, but in the meantime, let's see, we do have a Q&A that has popped up. Fantastic. Dr. Baah, this question comes from Amy Hamilton Forrester. And what she says is many patients with arthritis do not want to exercise to lose weight due to the pain that they experience. Is it best to encourage patients to continue the exercise process and work through the pain? She uses the example of using over-the-counter pain relievers or other pain relief methods, or should they focus more on portion control, diet, similar things to that?
Great question. So if you, going back to my slide, I was careful not to use the word exercise. The word there is physical activity, and physical activity for the most part means moderate exercise, moderate walking, brisk walking. And it's something that I know a lot of people with arthritis are in pain because that's the signature of arthritis, pain. You're always in pain. But of course, a little exercise, moderate exercise, brisk walking, 30 minutes a day, should be helpful in combination with watching what you eat will be helpful. But of course, yes, if you are in pain, you want to talk to your primary physician and get some medication. A lot of people are on pain medication, NSAID, for the rest of their life. But for me, I would prefer to make sure I do it naturally, especially in the early stages of arthritis, where I know I can reverse it, more like obesity. If you watch what you eat, and even if when it goes to diabetes, there are people who have had diabetes reversed just because they lost weight or they watch what they eat. So yes, I'm not advocating for high intensity exercise, but yes, moderate physical activity will be good. And I believe that even with arthritis, you can do that.
All right, Emmanuel, we had another question come in. Thank you for answering that one. This is from May Israel. They're asking, how strong is the genetic impact of arthritis, even with weight control?
Yes, again, it's something that I really wanted to avoid in this presentation because it gets murky when it comes to genetics. But I've been working with Dr. Komaya, I mentioned earlier, on so many genetic factors. So there are specific genetic variants that can even influence your taste. So obesity is not a simple thing. It's not about, hey, lose weight and the person is not losing weight and therefore the person is lazy. There's definitely a genetic component to it. Like I'm saying, there are specific variants that influences your taste. So you get individuals who might taste a broccoli and think it's the worst thing they've ever tasted, but you have another individual tasting it and it's different. So and of course, there are so many physiological also factors in terms of how your brain functions, in terms of what you put in your body. So it's complex, but yes, genetic has a huge influence on what we eat and how much we eat, and also who we become. Again, this study did not look at it. Actually, it's good that you brought this question up. So one of the things that we were looking for is to obtain the genetic information. Now, if you want to obtain the genetic information, you have to go through some levels of clearance, which we have done. And we did this in 2019. We requested for the genetic information in 2019, and we are yet to hear back from them. It's highly protected. So we wanted to look at how genetic play a factor in all these things. And again, it might take another 1 year or 2 years before we hear back from them, but at some point, we may have access to the genetic information and then analyze it further. Again, back to the question, genetic, huge part of this whole thing. So again, you just don't say, hey, you're being lazy, just exercise. It influences what you eat and everything else.
Thank you. Another question that has come in from Lisa. Are the inflammatory markers part of a standard blood test, or do you have to ask for them specifically?
I am not too sure about the United States here, but I think you would have to. So if you show up in your primary care physician's office and he feels you have some sort of infection, definitely they're going to order for the inflammatory markers. But if it's a regular checkup, you may have to ask directly, hey, can you check these for me? But of course, if you show up in the ER or your primary and he thinks whatever you're experiencing has something to do with infection, injuries, definitely they will order for the CRP and also ESR.
Perfect. We have another question that came in. Would a stretching or program, and they specify, I have not heard of this one myself, but it is called Sit and Be Fit, that sometimes airs on Channel 4, PBS, be appropriate exercise opportunities to help with those unable to do more strenuous physical activity?
Good question. I'm not sure I know about Sit and Be Fit. Okay, all right, I'll look it up.
Clever.
So the bottom line is anything to stay active. It's very important. Rather than sitting behind your desk, it's very important. But a big but here is we want some sort of moderate exercise. Walking is very, very important. So you may do all your stretches. You need to kind of walk to free up your joint and all those things. So yes, whilst any other exercise is recommended, you cannot replace that with simple brisk walking, 30 minutes a day, 150 minutes a week.
Wonderful. So those are all of the questions that have come in. Thank you again for your presentation today. There are lots of thanks coming up in the chat as well with great information, and I agree, great information and a wonderful presentation. I do want to just remind everyone that we are scheduling our first in-person Appetite for Life event next month in November. So on Wednesday, November 10th, we will be hosting in Kannapolis a forum, a community forum with our new director, Dr. Stephen Kirsting. So please stay tuned for more information about that. If you are on our mailing list, you will receive information about that event. There will be limited spots available. So when you see that invitation come out, be sure to get signed up right away. And just to bring things to a close for this afternoon, I will turn things over to Suzanne Dane, who is our Director of Community Outreach and Development. And we, again, thank you for attending.
Thanks, Sarah. Hi, everyone. Thanks to Dr. Baah for that really informative and interesting talk. I don't know about you, those maps of increasing obesity across the globe, and especially here in the US, were really sobering, as were all the economic and societal consequences of obesity that you pointed out. As you said, it's not just a health concern, but it clearly can have an effect on the prevalence of arthritis. I really learned a lot here today. I hope all of you did too. At the NRI, we're committed to bringing you programs related to our precision nutrition research that inform and enrich your lives. In addition to our science talks like this one today, we're adding some new types of programs in the coming months that you'll not want to miss. As Sarah just mentioned, we have this town hall style event and reception coming up with Dr. Steve Kirsting in November. So do keep an eye out for that information. When you receive our brief survey after this program, I hope you'll take a moment to let us know what you think so that we can continue to provide you with helpful and entertaining programming. And lastly, thank you for your support. The NRI is a nonprofit research center and relies on a variety of resources of revenue. If you're inclined to support our work, we welcome it. Please visit uncnri.org/support. So thanks for your time, sharing your time with us today. We hope to see you at future programs. Thanks. Bye-bye.